ready to go? Perfect. So, welcome everybody to the, special meeting of January 30th. Unbelievable, it's already, the end of January. This meeting's around harm reduction as always. When we like to start off our meetings, acknowledging that we're meeting here this afternoon on Treaty 5 territory, which is the ancestral lands of the Opaskwayak Cree Nation, as well as many other Indigenous people, and as well as the homeland of the Red River Métis. So with that, I will call this meeting to order. Somebody should have a resolution for the agenda.
Resolution number 2026-015, moved by myself, seconded by Councillor Manich, resolved that the agenda be adopted as presented.
Any further comments, concerns with the agenda? Seeing none, call the question. All in favor? There's Councillor Atkins is online, so we have 6-4, 0 against, carried. Councillor Hopper had actually sent his regrets for this today. He was unavailable. So as we just move along, thank you to Shauna from the Production Network and Krista, who is also in the room here with us, joining us this afternoon for this special meeting around talking about harm reduction. And I just want to start off by saying, this is it is an important topic. And I know there's a lot of strong feelings within the community around this, the frustration, concerns, and maybe even a little bit of anger. And that's completely understandable. Harm reduction does impact a lot of things around safety, healthcare, families, and just sort of the day-to-day experience of people living within our communities. So this meeting this afternoon is not about dismissing any concerns that people would have. It's not about telling people how they should feel. It's about trying to share information, I believe, from what Shauna is saying about sharing information with others, getting an understanding of sort of why things are done the way they are, and also, also provide an opportunity to share concerns that our community members have, so that if programs can be done and make things better, that's what we all want in the end of the day. So hopefully we can get something out of this. Hopefully people online, if you do have questions later, reach out to one of your counselors. They can always share that information, but also reach out to the service providers that we have within the community today. I mean, they're always open to discussions, and like I said, it's not about telling you how to feel. It's about maybe if we can just open our ears a little bit and try to understand. Doesn't make it better, but maybe there's a better understanding for it. So with that, thank you, Shauna, for attending today's meeting on our request. So we appreciate that. And I know you have a bit of a presentation, just for people that don't see, we have a couple of community members that are in the building. But this is really about a council being able to get some information from you, share the information with the public, and answer any questions that we may have.
Perfect. It's over to me.
It's over to you.
We'll make sure presentation's up. Here's something changed. Perfect. Okay, thank you for having me, folks. Thank you for the invite to join you folks. I do have a bit of a presentation, but I'm hoping to have more of a discussion. So I'll start with the presentation, and then if there's questions, folks can just jump in. Okay, excellent. And so I'm going to start with introducing myself. My name is Shauna Ilsley, and it's actually spelled Shohan Ilsley because I was born here, and Dr. Skelly delivered me, and he told my mom to spell my name this way, so I get to be Shohan. It's like Shaman, but the Gaelic spelling.
So it's not a spelling error in it?
Not a spelling error.
Okay.
Which I went through my whole life wondering if my real name was Shohan. So. But I do answer to Shohan, and I answer to Sho or Shauna, any of those. So I am from here. I went to school here my whole life. I spent my summers in Churchill, where my father was from. So I have the best of both worlds, I think, having Clearwater Lake and then having Hudson's Bay. So my parents are, my grandparents are Charles Ilsley and Emily Ilsley, and so some folks will know them from the community. And then my mom and my stepfather are Troy and Ahab Constant, and they currently still reside in Ocean. And then my father, who's from Churchill, is Bruce Martin, and he spent some time here back in the early days going to KCC for business courses stuff. And so that's how part of my life comes from Churchill as well. So who am I? So I am the executive director at the Manitoba Harm Reduction Network, and I have been there for 19 years. I do have a master's of science at the University of Manitoba, which is what got me out of living in this small town. I went to university down south and have stayed there since. But as the executive director, I just want to acknowledge one of the things we said was that I was going to talk about harm reduction. Now, harm reduction is, you know, a 3-4 day conversation on what all harm reduction is. What I hoped to talk about today is really just supply distribution, which is a harm reduction strategy. But in saying that, harm reduction is like a really.
Just 1 second, Sean.
Yeah.
Come on in, folks, if you wanna join, that's, no problem, just grab a chair anywhere you like. These chairs here are open, right after October, so if anybody's interested in sitting up here, just to put that plug in, then there's an upcoming election.
Thank you.
Sorry about that.
No problem. So harm reduction really is a strategy that all of us use in our lives, like stop signs are harm reduction, you know, Operation Red Nose is harm reduction, vaccines are harm reduction, like there's lots of things that we know can cause harm. And we want to figure out how to reduce the harms of those. But what I will talk about is supply distribution programs. When I spoke with Andre, when the invite came out, this was one of the things that he said is top of mind for people in the community right now. So this is what I will mostly focus on here. And then I will be returning in October, November to do some harm reduction training, which will absolutely be open to folks to join if they would like to see more about that. Now, thinking about supply distribution programs, so providing new needles is a harm reduction strategy, and it is done solely to prevent HIV and Hep C transmission. And so it's not about making it easier for people to use substances, it's recognizing that people are using substances, and we see HIV and Hep C numbers go up, and so we know we have to do some sort of an intervention to reduce HIV and Hep C, which are both communicable diseases. And so both of those are transmitted through the sharing of drug use supplies, and this includes not just the needles, but also the cookers and any of the other equipment people may use. And so the goal really is to ensure that everyone has their own supplies and to deter sharing and reducing risk for HIV and Hep C transmission. Now, supply distribution in Manitoba started many years ago at the Winnipeg Regional Health Authority level. That was in, I think, about 2008, and then it expanded in other areas of the province where we saw primarily Hep C rates increasing, which was an indicator that there was sharing of injection drug equipment, and we wanted to intervene to stop stop the transmission of Hep C. And then we also, one of the things Andre and I chatted about is, so why do we give out things like crack pipes and bubble pipes? And from a harm reduction perspective, we give it out because if we can get people smoking instead of injecting their substances, that's a safer way to do it. Now, remember, we don't come in and say, how do we support people to use drugs? We come in to say people are already using drugs. How can we support them to use them in a safer way, that's safer for themselves and safer for the community, so that we don't see HIV and Hep C rates going up.
Maybe
So-
Shauna, just a little louder.
Oh, sorry.
Yeah.
So when it comes to looking at why we give out safer crack pipes or safer bubble pipes, that really is about moving people from injecting their substances to smoking them. And even if we think about those of us who were around in the 90s, we will recall that methamphetamine showed up in our community in the 90s. And at that time, folks primarily smoked methamphetamines if they used them. As we fast forward to when methamphetamine showed up in Manitoba again, in about 2015, we saw people actually injecting them rather than smoking them. So part of our strategy is to say if there's a safer way to use it, can we move people to that safer way? And then, as people might say, wait a minute, but why are they using it in the first place? The other thing supply distribution does is it allows us to connect with people who use drugs who currently aren't connected to healthcare or social services, with the intent of if we can get them connected to healthcare or social services, we can also start to support them to access things like rapid access addictions medicine, or RAM clinics they're sometimes called, or other treatment facilities. So the goal is if we can get people connected to services, we might be able to help people move along in their relationship to their substances. Now, there's probably some questions starting to come, so if anyone wants to jump in anytime.
I'll just add one, so I guess, how successful are you, or what's the studies or the, I guess, how successful are we when we have this program connecting people, like, are they seeing it that it does work? And if you would say in our community, I know my friend Steven just walked in the room, is there the support services needed to be able to connect them?
So that's a really big question. So how successful are we? People are much more successful at accessing addiction services once they've been engaged with supply distribution than if they're not at all. But part of the challenge we know is what's offered locally. So what are the services? Is there addiction services here in the PAW? I'm not sure, but are there other healthcare services? And what the research shows is that once people start to connect with services, they start to have better outcomes in their lives. So sometimes their drug use may not stop completely or may not stop immediately, but they start to have different outcomes, like supporting them accessing care for their diabetes or supporting them accessing housing, things like that. So we start to see better outcomes. So yes, there's lots of research that shows because the alternative is just not connecting at all.
So what you're saying is the harm reduction, not just safe supplies
Oh.
distribution, there's a more to that program than that.
And what I will argue, Andre, is that we do way more other work than supply distribution.
You know, I don't wanna argue with you,
Yeah,
but
way more other work than supply. Supply distribution is a tiny bit of the work we do. It's mostly about how do we support people where they're at. And Krista can talk more about what that looks like here in the PAW. But some of that, for example, is improving access to healthcare services. Because we know the relatives that are struggling the most with their substance use, the number one place they access services is in emergency rooms. And we don't want them accessing in emergency rooms. We want them accessing at primary care or at a clinic long before they're sick enough to have to access an emergency room. Yeah. Yeah, so way more. We do way more than supply. And in fact, we have lots of harm reduction programs that don't ever do supply distribution because the folks who access services already have a mechanism to access their supplies. So now I want to just highlight our HIV numbers and our Hep C numbers in Manitoba because we are in the time of crisis in the province when it comes to both of them. As I talk about HIV and Hep C, I do not want to stigmatize either of them. People who have HIV and Hep C still have the right to the highest attainable standard of care, just like everybody else. But it is important for us to recognize that in Manitoba, HIV rates have stayed pretty consistent for a very long time, where we had about 100 new cases per year. And that was consistent, as you can see on the graph here. Oh, geez, I apologize. I switched this one. As you can see on the graph here, it stayed pretty consistent. 1 year in 2010, our HIV numbers went up to about 121, and that was quite alarming to see that high of a number. Following that, it went back down to about 100 per year. And then you can see on this graph, I apologize, it's pretty small, but if you, I don't have a pointer. If you can see 2020, it still stayed at about 100 that year. We had 98 new cases, if you're looking at the gold bar. And then it started to slowly increase after that, to the point where in 2024, we had 291 new HIV cases, which was quite high. And so high that it's now made us #1 across the country for the highest rates of HIV in Canada. It used to be Saskatchewan, and now Manitoba has
what's
the
the
highest
dotted
rates.
line? Profits.
The dotted lines are our rates, so that's just showing the
Okay.
rate, yeah. So the bar is the solid number of how many new cases, and the dotted lines are the rates that we're seeing. Now, according to the Manitoba HIV program, if everything stays status quo and we don't increase our interventions, then by 2028, we'll see over 1,000 new HIV cases in the province. And as you folks know, we recently had a cluster with your neighbors down south, just south of you in the valley. So we know that when we see a cluster somewhere, we want to really protect all of the communities around, because we know there's lots of back and forth in relationship with our neighboring communities.
How do you know, like, that, is there a way of telling that HIV is sort of with one group, and is there a thumbprint of it or something?
Yeah, so I don't have all of the science here on that right now. I certainly can pass that on, but there's things called mapping where we can look at what strain of HIV do people have, and then look at where did that strain come from, where we try and we don't have to go right back to patient zero anymore, but we want to try and see where is that coming from, so we can start to make some connections with seeing how the flow of it happens in the
Okay.
province. We do it, we've done it even like with syphilis, when syphilis started to come back again in 2018, we were able to do some mapping to see where that was coming from.
Yes, please, I just wanted to just give a little explanation on the rate. I can see the rate is 100,000.
Oh, sorry, I'm on the wrong slide.
Yes, this slide, just give a simple interpretation of the rate. In 2024 is, I can see 19.4, just give the explanation of what rate is.
So rate means per 100,000 people in the province who will have it. So that means 19.5 per 100,000 people in the province will be positive for HIV. Yeah, that's what the rate means. And we want to look at rate because that accounts for population numbers, right? So the rate is the really important number that we want to look at. 2025, this is Manitoba HIV programs graph, but 2025, our numbers are, I'm going to say 20.3, but it might be 20.1 per 100,000. So it's gone up still.
Do you bring those stats up by region?
Questions have to come from council, so this is not an open forum.
Okay,
So, I mean, we can, unless council is okay, this is not typically a council meeting where the public's involved. But you did hear the question and,
okay. What I can tell you is that there is a dashboard. It's called the Sexually Transmitted and Bloodborne Infection Surveillance Report, and they can break it down per RHA. There, you can see the breakdown there.
and I don't know, sorry, just a municipal act, rules. Are we able to have members of the public ask council questions at this meeting?
It's a special council meeting, so it's only council member that can ask questions. However, member can ask probably after the meeting.
Yeah, and I'm happy to hang around after the meeting to answer.
Yeah, so
I requested for that interpretation.
So I think we
want
should
people to
establish now and
understand
after the meeting.
what those
of a
number means.
special
Yes,
I
agreement.
do understand it, but I just want people to.
Thank you for that, yes.
Yeah, so as Councilor Manish mentioned, so after our meeting, if somebody wants to hang around and ask some questions, hang around, just I don't wanna make sure we follow our rules. Not that I like all the rules, as people know,
But I want to make sure that everyone who's in
Yeah.
attendance, that I have an opportunity
Yeah.
to make sure that.
No, for
it's
sure.
very clear for folks. Yeah, excellent. Yeah, so that's where we are at, and thank you for the question about the rate. Following the meeting, what I will do is I will make sure that I send BOLA, based on any of the questions that come in, I'll send BOLA additional resources that maybe could be available.
we'll put it in part of our meeting agenda, online, so people can just go in and they've already can see the presentation. They can also see any other data that's connected to this meeting.
Perfect.
So one question I have for Shauna, the increase that we're seeing in the HIV rates, is it being primarily driven by sharing of needles and other?
So I have a slide on that. So when I get to that slide, let's make sure that I answer those questions at that time. The answer is yes, some of it is. Yeah. And then we also are seeing an increase in hepatitis C. Manitoba has had the highest hepatitis C rates in the country for quite a number of years. And so we still continue to be the highest for hepatitis C. HIV is not curable, but it is treatable and people can live well. We have folks 40 years into their HIV diagnosis living a good life. Hepatitis C is curable. So there is a treatment for hepatitis C, but hepatitis C you can acquire again. So even once you've been cured, you can get hepatitis C again. And so one of the things I just want to point out in our province, and this relates to why we do the harm reduction work, is that if you look at the slide, I wish I could show you, but in the little blue box, it says 631. That was the number of new hepatitis C cases in 2023. As I want to make sure I'm saying the right year. And out of those, that same year, we only treated 217. And knowing that this is curable, if there's 631 people diagnosed, we want to treat 631 people to help prevent the spread of it, right? So that's part of the goal of a harm reduction program, to say how do we engage all those folks who are living with hepatitis C so we can also get them into treatment, because we know that treatment is prevention. If we can treat people for their hep C, they won't transmit hepatitis C, for example. and HIV. If we could treat people for their HIV, they'll get what's called an undetectable viral load, and they won't be able to transmit it. So those are some of the goals we have. So one of the questions that Trent asked was, why are we seeing an increase in HIV and hepatitis C? And important for us to recognize the pandemic had a significant impact. And part of that impact was recognizing that public health had to mobilize to respond to the COVID crisis. And when that happened, we saw a significant decrease in access to supply distribution. And at that time, the folks that we were connected with that inject drugs were starting to report sharing of injection equipment again. And this was a group of people who were not sharing prior to that, but because they no longer could get access to new needles, they started to report a sharing again. The other thing to note is that while public health mobilized to COVID, they also, we saw a significant reduction in access to STD/BI testing. So that means we didn't have people getting tested for chlamydia, gonorrhea, HIV, Hep C. And what we know is that once people test, they get the results, we treat them, and treatment is prevention. Because if I have chlamydia and I get treated for chlamydia, I'm not going to transmit it. And it's the same thing with HIV and hepatitis C. If I get treated, I'm not going to transmit. So we saw a significant decrease in testing. And then coming out of testing, we knew that there would be certain targeted populations that were going to see overburden for HIV and Hep C. And so we really focused our testing events on that. And here, even in the fall, we have what's called peer-to-peer testing events to bring people out to get tested, followed by treatment events, so people can then get treated for their STIs. And then let's talk quickly. Oh, sorry, did I answer your question, Trent? What was your question again?
Yeah, I think you've answered it, yeah.
Okay. And then the question becomes, thinking about publicly discarded needles. The first thing we want to note is that most needles distributed get already disposed of safely, whether it's in people's homes or not, which most of the folks who access supply distribution sites are housed. So they do have safe places and safe ways to dispose of it. But the number one cause of publicly discarded needles is public drug use. And the number one cause of public drug use is homelessness. Right, so it's only when we see an increase in homelessness that we sometimes will see an increase in publicly discarded needles. Important for me to note, not all people who are impacted by homelessness use substances, and not all people who are impacted by homelessness use injection drug use, right? So really important to recognize that. And so that is the number one cause of publicly discarded needles. And then I'm just going to talk a little bit about community needle stick injuries. This document comes out of the BC Centre of Excellence, and I will make sure that this is a link with your minutes as well. But I'm going to just zero in on a couple little things here. When it comes to needle stick injuries, people are quite concerned about, and rightfully so, concerned about needles discarded in the community. We definitely don't want to see that. And so when we do see a needle, there's a few things we want folks to know about risk. One, and important for us to note, is that globally, there is no documented cases of HIV infections occurring due to an accidental needle poke from a publicly discarded needle. So that has to date not happened. What we do recognize is that risk for transmission of anything, particularly HIV, Hep B, and Hep C, in publicly discarded needles is low. Why? Because the injury doesn't occur immediately after the needle is used. The needle rarely contains fresh blood, and any virus present has been exposed to drying or environmental temperatures. So for example, HIV, outside of the body, HIV could die within minutes. And in ideal conditions can live only up to about 2 hours. That's in ideal, mostly laboratory type conditions. And then often the injuries are superficial. But I don't want to say to people like, don't worry about it, there's nothing to worry about. We definitely do want to recognize, what should I do if I'm accidentally poked by a needle? We certainly want everybody to attend to healthcare services, because folks in our healthcare system are well trained to establish risk. And then there's also some medication you can take after a needle poke if needed. And there's some tips here on what happens if you're poked, what you should do. And that includes allowing the wound to bleed freely, washing the wound with soap and water afterwards, and then immediately going to emergency services where they will do an assessment.
Can I just ask you just to clarify, because I'm not sure I heard, so are you saying that there's never been a transmission of HIV from a needle poke?
From a publicly discarded needle. So
Publicly
the only
discarded?
place we've ever seen transmission is in a healthcare setting
Okay.
where people accidentally.
Yeah, okay.
Yeah. There has never been in a community setting where a needle has been discarded in the community and somebody poked themselves on it and got HIV.
Yeah,
Yeah.
so no, so that risk is there. It's just
In a
it hasn't
hospital
occurred. In a hospital,
situation.
well, it's in the public as well, because it could happen, but it just hasn't.
It has never happened
Yeah.
here. And the reason why it's never happened, particularly for HIV, is because it dies very quickly outside the body.
Yeah.
Yeah, it could die within minutes of being outside the body. Yeah. Yeah. And then, of course, there's lots of things we wanted to do. Oh, geez, sorry, folks. I have 2 slides here, so I apologize. There are things we want to do and that we do in harm reduction programs to always decrease the likelihood of publicly discarded needles. And so one of the things we do is when people pick up new supplies, we also provide them with Sharps containers. And so as we see our levels of homelessness across the country increasing, it's not a thing here in the PAW only, it's happening everywhere in the country. And in fact, if we look at Winnipeg, Winnipeg's homelessness population doubled since our last what's called a PIT count, a point in time count. So we know that because of the cost of living increasing, we're also seeing homelessness increasing across the country and across many of our communities. Now, why is that important? That's important because when people were housed and they picked up supplies, they would take a Sharps container home with them too, so that they had a safe way to dispose of their needles. When people are not housed, taking a 5-liter gallon bucket home or outside with you is not as easy. One of the things we have done in our supply distribution programs is if people are impacted by homelessness, we have small discrete containers that people could take. They only hold up to 10 needles though, so there's some limitations on that. But we do want to make sure that in addition to providing any Sharps containers we can, we also, everyone who does access harm reduction supplies gets trained on how to safely dispose of their supplies. Just like if somebody was accessing needles for their diabetes, they would get information on how to safely dispose of their diabetic needles, for example. We always want to make sure people are well versed in how to take care and dispose of their needles.
Maybe you're gonna get there, but if, you know, we're talking about having a hard time having these collection containers. So why don't we force people to actually just bring them back to replace them? So that you bring them to a place where they can be collected.
So to be exchanged?
Yeah.
Yeah, so there has been programs globally that really were about exchange. And what we found was that it actually would lead to an increase in HIV and Hep C, because if people have it could lead to an increase. There's been evidence to show it does, but there's some other risks that happen in the community. So if I have to bring back the 5-gallon pail, I'm now transporting biohazards through town in order to come back and get 25 new needles, right? And then there's programs that are designed specifically for certain target populations to say, let's make sure we do an exchange. But if they got 10 needles and they come back and only bring 5 needles, then they only get 5 new needles. That actually has been shown to increase HIV and Hep C rates, because then people only get the 5 versus the 10. So then we see an increase in sharing. So and remember, the only purpose of supply distribution is to decrease HIV and Hep C transmission. So then it's been found to not be as effective. Did I answer your question? Yep.
So you're saying that it's more dangerous for them to bring the needles back. So where do they put their needles? In the garbage or the recycling center? So those people are at risk,
Yeah.
right?
So lots of
How
people.
big is at risk?
Yes, so I'm not necessarily gonna say yes, there are lots of people will dispose, just like if they have needles for medication and stuff, they will dispose of them. We train people to put it in a puncture-proof container, and then often it gets thrown in the garbage and then goes into the landfill. We do know that it would be much better if they return, and people who have access to transportation will bring their needle containers back to distribution sites or to their pharmacy, right? Because pharmacies can also collect needles in puncture-proof containers. So that's how the training that we provide is here's your container to dispose of your needles, and then take them back to the pharmacy or take them back to your local, if the RHA, for example, collected them, then we would have them take them back to there. Wherever it is, depending on the community, what disposal looks like.
There's a major problem at the recycling center,
Okay, yeah,
major.
and rightfully
People are
so.
putting, they can't recycle needles
No, you cannot recycle.
and must be dumps too, so.
We definitely don't want it to go into recycling, and I know one of the strategies that, so the other strategy, of course, is to have bins located where people are finding, publicly discarded needles. And so that could be a myriad of different, kinds of disposal bins. I know in Winnipeg, at one point, we had, bins that were designed specifically to sit on hydro poles in back lanes where we were finding, publicly discarded needles. And then many communities, put up the actual larger drop boxes, right where people are finding publicly discarded needles.
I'm not saying people purposely put it in recycling.
Mhm.
I'm saying they're putting their garbage into recycling and therefore it's getting into.
The
their
recycling,
stuff,
yes,
yeah.
yeah, absolutely, yeah.
So,
Or sometimes people will just be like, where's the closest garbage can? And sometimes that's the recycling versus garbage.
Yeah,
Yes.
so that's a good point, and I know Krista may have to jump in and help you with this, but is there in our community, do we have any sort of formal collection process going on?
So there's the two drop boxes, one outside primary care and the other one outside the emergency room, correct? And are there any other, and then important to note, like the wellness center has a needle drop box, your airport bathrooms probably do. Like there's other different places where there's also access to needle drop boxes. Beatrice Wilson?
Yeah, and then the one that we put in under the bridge.
Yeah, so there was a committee, formed a while ago, and, the NRHA a couple of years ago placed it was a couple of years now, placed a large area where people were using underneath, in a location in town.
Yeah.
Um,
Wherever we find them, that's where we want a couple things to happen. We want to put a needle drop box there, and then we also want to have outreach teams to visit those areas to talk to people about, let's talk about how to safely dispose of your needle if you're going to be using here, and show people where those drop boxes are. So it's not just putting the box, it's also doing outreach so that people know, where the option is to drop their needles, yeah.
But how do you get them home to use those spots? Yeah, I live in the downtown area and I see needles all the time. In the parking lot next door to my place, my granddaughter picked up a package of needles one day. And, Papa, what's this? And I said, drop that. And she had a package of needles, and one needle was gone up. So they threw the rest on the ground. They just were after that one needle to get through the night, and they don't care. So many of them don't care. So you're putting children and other people at risk at all times. If you had an exchange program, then you bring in 5, you get 5, you bring in 10, you get 10. If you lost 5 of them, you only bring in 5 whole ones, that's on you.
And some of it, absolutely, like we definitely don't want needles sitting in the community at all, whether they're used or unused. You indicated there was some unused as well. We definitely don't want needles sitting anywhere in the community. So wherever we do see that there's needles, and we have often done, ever since we've had a Plant Safer Network here, we have done community cleanups every spring. And for many years, we never found any needles in the community. And then we start to see, we'd find 1 or 2 here and there. And then wherever we did find needles, we would talk to folks to be like, hey, what's happening that we're finding needles in the community? We do know that all of our communities are reporting an increase in finding, publicly discarded needles. And so the question becomes, how do we have like a committee that says, how do we want to address these needles in the community? And everybody collectively working together to mostly social services, to do some of that outreach, to talk to people about why are you discarding needles publicly. One of the things we do here is that people often, not often, people will sometimes fear police. And so if police come around, they'll indicate that they'll throw their needles away for fear of being caught with drug paraphernalia. And so we want to make sure that people aren't just holding on to their needles anyway once they've used them. As soon as you use them, we want needles to be a single use, and right after you use them, you immediately have a safe place to dispose of them. That is the ultimate goal. Recognizing that most people who access do safely dispose of their needles. So then when people aren't doing it, it's a matter of having outreach teams to go out and say, hey, what's happening that you're not safely disposing of this?
Okay, so it's still illegal, but we're handling on the needles. So if you get caught with them, you're gonna get charged.
Well, here's
Give it
the,
To them.
yeah, here's the tricky part of the law, is that the law is that it's not illegal to be under the influence, it is legal to be in possession. And so that's why the possession piece becomes hard, because then people have fear of being in possession of it. Yeah, it absolutely is an illegal activity, for sure. And so the public health approach is, if people are engaging in this behavior, how do we stop transmission of HIV/FC? Less about, how do we stop people from engaging in an illegal behavior, because we won't ever be able to do that. People have used illegal drugs since time immemorial. Used substances since time immemorial, and then we have a long history. And in fact, in our research, according to the Canadian Centre for Substance Use and Misuse, 70 to 80% of people have used an illegal substance in their lifetime. And so it means that it's here, people are using it. So how do we address the demand? Why are people using substances? What's going on? And this, of course, leads to, and I'm going a bit off topic, but it leads to having really robust mental health services and addiction services, so people can get the supports that they need. And unfortunately, I can include a link that talks about Manitoba's access. In 2019, the government of Manitoba commissioned a report that was later coined the Virgo report, which really looked at what does addiction services look like in Manitoba. And the conclusion was that we have a pretty fractured system that leads to people waiting anywhere up to 9 months in order to access addictions treatment. But that's when they're already in the system. Prior to, it takes a heck of a lot of work to try and get into that system. So for example, in the pod, you guys have a treatment facility here in the pod.
Yeah,
Do you?
well, Rosaire House is a treatment facility, but it's not, I don't know how effective it is, but it is a treatment facility.
Yeah, and that's part of the problem, is we really need to look at the whole
Yeah.
plan. Is like, we need people to be able to access
Yeah.
and be successful in treatment as well.
It's not an instant, like we've talked many times, it's
Yeah.
not if somebody acknowledges today, there's a waiting period. Before you even get seen by somebody, likely that decision will likely change and you will be ready again, so,
Well, and our system says you have to detox first, and I
Yeah.
don't think there's detox here.
no.
So if there's not even detox in the town, and in order to go to detox, then you have to go to Winnipeg. And in order to go to Winnipeg to detox, you need a doctor's note, like an assessment done by the doctor.
Yeah.
And that assessment lasts 72 hours, which means you have to get to detox within 72 hours.
Yeah.
And then, but you have to get a doctor's note. How long does it take in the pod to go to the doctor?
Yeah.
To make a doctor's appointment, right? Like, the system is so, there's many challenges.
No.
But what I will tell folks is that, and which is on here, is I talk about housing and housing first programs. So when it comes to problematic substance use in our communities, housing first models have been much more successful to decrease things like public drug use, and ultimately people in public being intoxicated as well. That's the other issue, right? Is also people in public being intoxicated, as well as publicly discarded needles. So then the question becomes, what programs are currently existing in the community, and is there a way to increase housing and housing first programs to support our relatives to get them into homes where we can have some really great case management models where we can support people to stay housed. Which is where some of our relatives like CMHA and stuff can come into play here as well. And then, right there, I'm done. So I'm happy to take any additional questions. Yes.
Is there anything out there that they're going to get a treatment center up north here?
That is the dream.
Please and thank you.
So as far as I know, there is nothing in the works for a new treatment center here in the PAW. I do know that there has been some RAM clinics. I think Thompson now has a RAM clinic. Does the PAW have a RAM clinic? A rapid access to
No.
addictions medicine clinic?
Not technically, but I just saw some info that we're gonna have something.
Okay. So you might be getting something soon, and you do also have, Beatrice Wilson has an OATS program, which is an opiate antagonist treatment program, which is also part of that whole addictions medicine. But a treatment facility,
Well, we
every
can,
community should absolutely have.
we have actually signed letters of support with Swampy Cree and what's Frank turn. They've got a plan and we provided support letters for them to do some sort of facility out of town as well as support around OCN and Egg Lake, so there's been lots of that, but there's been nothing that I'm aware of by the provincial government identified or earmarked or in a schedule to be done in the fall.
Yeah, nothing that I remember. I think the closest to you guys besides Rosaire would be,
Well,
well, yeah, some people to Brandon, but, and then, St. Rose.
yeah, St. Rose, yes.
And Thompson has a couple things now, but I have not heard anything about the pot getting it.
My opinion is that there should be one. We have a lot of land around here, lots.
Yeah.
Now, everybody in our community needs to be safe.
Absolutely.
Everybody, the ones that are, you know, suffering from drug use. And they are not safe. They need a place where they can go, if they'll be safe, and they don't have their friends visiting them, or open door, where you can go outside and you can do that. They need to be safe too, and they do not feel safe.
Yeah.
Rosaire House, it is not a safe spot, and that has to change. The government is not doing enough.
Yeah.
With it, with alcohol, with drugs. Larry and me, we both have businesses. And I'll just give you a quick example. I walked out of my shop today and there's this truck handing one of the street people a bottle. So I'm thinking, oh, wonderful. So I watched, and there they were going into the next door, and they have a little cubby hole there, and they're drinking it. I said, don't go on. Went to the liquor store and said that's what happened. And they said, well, it's really out of our control. We have CSOs. And I said, you know what? The CSOs are doing their job, and the cells will be full every day.
Yeah.
So you have alcohol, you have drugs, and there's the government not doing anything about the alcohol being thrown out on the street. I'm sorry, they're not. That is a joke.
I agree. I agree.
Sorry,
And I
sorry for raising my voice in that, but when you see it day in, day in, day out, and we run a business, our whole downtown. People don't want to come downtown anymore. But oh no, let's keep on selling the alcohol. And they had a thing where if somebody bought so many bottles during a day, then you're on this list. Oh, well, we can't do that anymore. We have to. So,
Yeah.
Sorry.
And so I just want to comment on one thing you said, which is like having a safe place to go to. And that's the beauty of Housing First programs. And CMHA folks can talk more to this than I can, but when we have the Housing First program, there's built-in supports right in the housing units so that it helps to keep safety for everybody who's in that unit. So a bunch of people can't just come and party in your unit. It's about how do we keep people safe and work to keep people housed. Because when people are housed, we know there's better outcomes for them when it comes to their relationship with substances, whether it's alcohol or cocaine or anything, right? They have better relationships once they're housed. Because the other thing that happens is once people get housed, the next thing they look at is employment. And we know for adults, the #1 alternative for substance use for an adult is a job. And so even if we think of during COVID, according to Canadian Center for Substance Use and Misuse, during COVID, when all of us had to stay home, there was a significant increase in alcohol use. And then when we all got put back to work, we saw a significant decrease in that. So 25% of people, up to 25% of people, they broke it down by age category, but up to 25% of people reported an increase in alcohol use in the first 3 months of the pandemic. And they reported it was because they had time on their hands was the #1 reason, followed by boredom. And so once we house people, we know that their next goal is how do I become employable now? How do I get a job in the community? And that in itself decreases substance use.
So you part of the alcohol too, or is it just drugs? Is it alcohol and drugs, or you're just part of the drugs?
Oh, no, we also work with folks who alcohol is still the.
No, it's
mostly
not drugs and alcohol, it's
Yeah,
not the same
yeah.
thing, and the marijuana and everything and that. But I'm just saying, if you can go into the liquor store and buy, there's no limit of amount of booze that you can buy. And you don't have a license, I just don't understand that, I'm sorry.
Yeah, and I don't know the regulations of that. I'm not as familiar with all of the regulations with that and what people can and cannot buy, but I do know that people will go and buy significant amounts of alcohol.
Yeah. That's, it's.
Yeah.
Yeah, it's money for them, right?
Yeah, so do you guys have any housing for smalls here? I don't know if I'm allowed to ask the
Mm-mm.
Yeah, no, you can ask council.
council, do you guys have a housing for small here? No, okay. Yes,
So I have a whole bunch of questions, so I'm sorry, we're gonna go right back to the beginning, because I tend to like the presenter to do their presentation and then get into the discussion, so sorry for backtracking a little bit.
that's
One of my biggest questions, I guess, is does the RHA work with your model? Do you work in conjunction, or is it simply they have their own processes and it happens to model some of yours? Or is it, in other words, if we were to say, hey, we want harm reduction to look differently,
Mhm.
many times we're told, no, that's an executive decision by the RHA, therefore you can't impact it.
Yeah.
As an example, I would love to see a needle exchange,
Mhm.
right? I understand your statistics, but those statistics don't then support the wellness of our community, right? They help the users, it helps what the goal is, it's kind of working in a silo. What I would like to see is, yes, you need 10 needles, you bring in 10 needles.
Mhm.
I understand your stats, but it then gives opportunities for the people at the RHA, for example, primary health, where they're getting these needles from indiscriminately at times. I said, one of the biggest things I hear from community members is, well, they go to a filing cabinet at the front of the hospital to take everything they want. And as Councillor Forrester has pointed out, a lot of times they're unused needles. They're playing darts with them on the street at times, right? How would this council be able to respect the goals of harm reduction while still taking care of the community's well-being?
Right.
How do those mesh together? Because again, harm reduction is a bigger picture than we're explaining today. However, we don't have wraparound services. We don't have housing. We don't have addiction supports. So at the end of the day, our homeless center, which I refer to more as transient, because we don't really have a homeless population. We have people that have been displaced, but it's not like an industry shut down in Paw, and now we have all these people that have nowhere to be. We've had people that have come to our community because of some of the services we're offering, and now they're displaced here.
Mhm.
So again, the easy way to answer my question is, how do we support harm reduction while at the same time, not working in a silo, support the well-being of our community? And again, one last thing I want to add, in no way have I ever fear-mongered or been concerned about being poked with needles. When I was the fire chief, I would go put out fires in the dump and my gear would be full of needles poking me. I never once thought, oh my God, I'm gonna contract something.
Yeah.
But I think of a child going down a slide at the park, being poked, what mental health issues does that child now have?
Mhm.
What the families have? So the picture is much bigger than
For sure.
that part, and mental health is just as important as a physical health, right? And we all know somebody that's scared, terrified of needles.
Yeah.
So it's the stigma that's attached to being poked,
Absolutely.
not the health concern in that sense.
Yeah, and we definitely, we don't want to see needles anywhere in our community. We certainly don't want to see them anywhere where our children are playing, for sure. I want to answer your first question, how do we work with the RHA? So we work very collaboratively with the RHA. And from a public health perspective, and to be clear, what you're talking about is less about informing our harm reduction programming, it's about informing supply distribution. So I want to be really clear, like harm reduction is a big model of care. And supply distribution is just a portion of that.
Yeah, I understand. My questions are very general as well.
Yeah.
'Cause like I said, we could
So
be
what-
specific.
So we work very closely with the RHA. When it comes to supply distribution, the intent is to reduce HIV and Hep C transmission. And when we can reduce HIV and Hep C transmission, that does protect overall the whole entire community when we see our rates go down. Now, with that said, we certainly want to look at what is evidence-based practice for community safety in general. And if HIV rates and Hep C are going up, and like, I didn't have time to come and talk about, like, let's look at all the different exchange models. And where different exchange models have been evidence informed and stuff, and what makes the best practice. Because at the end of the day, we want to make sure we balance this with, yes, there's harms to this. Are there more harms to not having it? Or those harms, how do we mitigate all of those harms? Is there a way to mitigate them? Because if we just remove the program, then we see HIV rates going up. And important for us to know, when we're talking about HIV rates, the only way HIV is transmitted is not just injection drug use, it's also transmitted sexually, which means it can impact everybody in the community. And we have young people included who are being impacted by HIV from sexual transmission. So we want to make sure that we're protecting all, like, it's so much more than just the needles, right? Maybe what I can propose to do is come back to give you, in the future, the evidence around exchange and what that looks like. And then, because part of it is, even if we did exchange, we would have a bunch of different harms, and we would still, as a community, have to figure out how do we address those harms too, right? So either way, it's about saying which one has less harms or which one has harms that we can address in a, like, with the resources we have in our communities. Yeah,
So
it's tricky.
and for
It's
sure,
about
you have
what's
to
the
try to
outcome
balance
you
which
want.
one's more beneficial and more
Yeah.
harmful.
Yeah.
And I understand, but again, it feels like it's a bit of a silo, right? Hey, we're trying to
Yes.
prevent the transmission of diseases.
Yeah.
But my role as a counselor is to say, but what about the other 5,100 people that aren't directly impacted?
Yeah.
But knowing that there's spaces that should be as safe as possible aren't
Yes.
because of possibly indiscriminate needle handing out. And again, I'm not saying that it's all the reason, but we know by them being available, it definitely contributes to it, right?
Well,
And-
well,
and
not
in a lot-
making it available, I wanna be clear, we don't see publicly discarded needles because there's needle distribution, we see publicly discarded needles because of public drug use, which is because of.
For sure, absolutely.
Right, like, we
Yeah.
wanna be really clear, most of the people who access any supplies are housed and dispose of their needles safely, whatever that looks like in their community. Publicly discarded needles is very much connected to public drug use.
For sure.
Right, which most drug use isn't happening in public.
Yeah.
So then the question becomes, why do we have public drug use and how do we address that public drug
And
use?
when I say indiscriminately, like I said, you go to the filing cabinet at the hospital.
Yeah.
One of the things I like you saying is by having the harm reduction strategies, it allows us to connect with those people.
Mhm.
But if you have a filing cabinet in the corner, there's no connection. There's no education provided, there's no safety provided, it's simply providing paraphernalia. So I'd like to see that change by an exchange, because then it forces them to go and see someone like Krista or go to primary health and say, if you want these 10 needles, then let me have us talk with you. And yes, it's gonna lower your rates of success from that smaller silo you're working in.
Yeah.
But it's gonna limit how many needles are in our parks and in our community. Again, it's not science-based, that's my
Yeah.
opinion. But again, if we're handing out 1,000 needles a day and 1,000 are being returned, even if it's 5% less on our street, that's a success.
Mhm.
The fact that maybe one less person contracted HIV, I'm not being a monster and saying that becomes a public health issue more so than it is about the 15 children that could be exposed or the 15 animals. And hearing you say, well, the exchange puts in harm by bringing needles, it puts those receivers in harm. But then we suggest having community cleanups to clean up the needles all throughout town. So again, we're kind of like that, we work in a silo, and I just want to see how do we come together to ensure everybody in our community can be satisfied
Yes.
that the best efforts are being made.
Totally, and really, when it comes to publicly discarded needles, it's really like how do we have a robust response to decrease that and address that so that doesn't actually happen in our communities?
So,
It can't just be like a one-stop shop, right? Like, that's why we have a wellness center that has needle disposal boxes in all of their locker rooms, right, and stuff, so.
and this may not be a question you can answer, but so if this council supported the idea of saying, we're only going to allow an exchange in the community, is that a possibility, or is that more of a legal question that would have to go through the RHA agreeing to it as well?
Yeah, so that would go through the RHA, because even for us, when we do supply distribution, it's in partnership with the Regional Health Authority. And we do it based on the fact that we have access to a different population of folks who maybe the RHA doesn't have access to. We do distribution to the folks that we provide services to. If they're not already accessing from the RHA, right? Some of them might be. And when we do it, it's always about, here's how you also safely dispose of your needles. So if you wanted to change it to be, if that's an RHA evidence-based intervention, we have to follow the agreement we have with the RHA to say this is how we'll give out supplies. But I think there's opportunity for me to come back and say, let's look at what a needle exchange could look like and where are the parameters where that would be a potential option to do that. And I want to talk about the cupboard for a second, because some of our communities have lockers. And so we also have our health boxes in different places in the province where people go up and put their hand on it and then they get supplies through that. The intent of that is to increase access after hours when people are not available. And I can't speak too much to your your cupboard, because I don't know, I haven't even visited it. But the intent is to recognize that, in order to get supplies, you don't have to get it from a healthcare provider. So for example, in our organization, no one's a healthcare provider, we're all social service providers, who really work to link people into care. And so when people come to see us, in the moment, we definitely want to have that conversation, but back in the day, there was also discussions at one time about condoms, and should condoms be readily available, because we might see them in the community, like it was the same kind of in our generation, right?
Yep.
Like in school and stuff. And so the question becomes, how do we balance the needs of some folks in our community with the safety of the entire community? And that's really a robust conversation. That's less about like, let's talk about just this cupboard, and more, let's talk about safety of the community in general, because we know that even if we got rid of that cupboard, there would still be discarded needles if there's public drug use happening, right? So, and even if we did an exchange program, we would still have publicly discarded needles,
For sure.
right? So it means that can't just be the end all, there has to be a whole plan that's a community-driven response to it. Yeah.
But,
Okay.
so isn't, you're having that, okay, covered at the hospital, isn't that an increase in, traffic? At all hours of the night?
I don't know the details of I can't speak to that, that would have to be an
I'm just
RSA
making
question,
it- I'm
yeah.
just kind of asking a question, but making a statement, so you could go there and, and send your kid in there to get their drugs. And if somebody's lying in bed in ICU, and then there's somebody doing drugs outside their door, yeah, it's an increase. So
Sorry, you said.
it should be policed, it shouldn't be just, oh, you can go in there and get your drugs.
So what,
Get your needle.
there's drugs in the box?
No, you can go get, there's not enough policing, anybody can go to the hospital, right, if I'm wrong. And they can go get their pills or their
Paraphernalia.
paraphernalia,
Yeah.
whatever, and then go in the parking lot and shoot up, or they can go at any time of the night, and there's kids in the vehicles, and
So what,
it's added traffic.
Yeah,
And people go to the hospital because they are sick or dying, and you have to walk through this or see this.
Mhm.
is it attracting, I guess what Counselor's saying, is the current distribution system attracting people to an area where there's already a lot of people that are dealing with other health concerns? And
Yeah, I can't answer that one, sorry.
I can't.
I'm just saying,
But I do want to make sure, because you said they can go get their drugs, and one of the discourses is that, Harvard actually, we give people drugs, we do not give.
no,
people drugs.
no, I corrected myself, they're drug paraphernalia.
Okay,
No.
okay.
No, I know they're not getting their drugs from there, but they're doing, yeah. And I've seen them in the hospital, they're doing their drugs in the parking lot and 2 days in a row. So you know what, when somebody's sitting there in ICU, that shouldn't be happening.
Well, and we do know that when people are using either public bathrooms or using outside, it's a sign that they don't have somewhere else to use their stuff, because nobody would want to use outside if they had the option to not use outside, right?
One question I did have, we talked here a lot about people getting poked by needles. Is there any stats on how many people are actually getting poked by needles at the public?
Winnipeg Regional Health Authority might have that, but. So I can't answer that stat, it's very rare if ever, yeah, it's very rare, Trent. They're actually, I'm gonna send you something from 2019 that actually did have some numbers, because I think globally, I'm gonna pull it up right now and I'm gonna tell you what they said, 2019. Sorry, give me a second. I will send this forward, but I think at that time globally, between 99 and 2013, there was a reported, I want to say around 1,500 folks globally reported from publicly discarded needles.
So, I mean, no stats from Manitoba, obviously, but we're not talking hundreds of cases here in the province.
No, the cases the needle poke cases that we do have documented are primarily in healthcare settings or social service settings where there's some distribution stuff happening. That's where we see it. And then, of course, there's policies about making sure you report to the emergency room immediately. Yeah.
And so like I definitely don't want to diminish the concept of the thought that this is a safety issue, and don't want to disagree with anything that Councillor Manich and Councillor Commodore said, but to me, I'm taking this more as this is a optics issue. That if we didn't, and thank you for bringing up the homelessness part, I've always felt that the biggest drug, or the biggest problematic drug is alcohol. And we have problems with people drinking on the streets, but there's far more people drink in their homes and have alcoholic problems there.
Yeah.
They're not a problem because we don't see them.
Exactly.
The same thing with the people that are using the needles and then doing the drugs. As soon as they're in the home, we don't see them. Their needles hit the garbage, we don't see them. It's an optics issue. So basically, I think what we're all around about trying to get at is how do we reduce the options? How do we collect these needles so that nobody's seeing them? Because if we don't see them, we're not all here talking.
And just to add to that, when we talk about optics, I also think it's perception, because I think there's a big misunderstanding of the risks and the concerns around that. But I will also support what my counselors are saying is one's too many.
Yeah.
When we see them on the street, and so, and I don't, everybody has different feelings and different concerns and manages risk differently. So we need to recognize that, and if there's ways of improving the system, but I would say personally, I've been on pretty well every community cleanup that's taken place in the community since I've become the mayor anyways. And to find a random needle in the middle of downtown, I personally haven't seen that. I have found needles in areas where people were actually using under a hedge or under a tree, and discarded. And as I think Councillor Manich had mentioned, I have found unused needles, or Councillor Forster has mentioned, I haven't found needles in parks on swing sets, and that, not to say they haven't been there. But I think this is the perception and the belief that's there. And the concern is really gets driven by the risk or what the impact is or the consequences with that.
Yes.
And I think this conversation today is important, is people need to understand what that is. They don't have to like it. And, I'm gonna say, I'm not completely sold or don't completely like handing out needles either, but I have to understand the whole concept of it before I can say we should do this or that. And so I like, I continue to learn, and I appreciate what was brought forward, so.
And we still don't want even one needle.
No,
right?
exactly.
Like, we don't want that, and it should be alarming if we're finding a needle in a park.
And-
It's about making sure that everybody who finds a needle knows how to discard that needle safely. And the other thing I want to note is that we have our peer advisory councils, and our peer advisory councils regularly will report, hey, there's needles in this place, and then our team with the peers will go out and do community cleanup randomly based on what's happening in the community. So we know that the majority of people who also use substances and are impacted by homelessness don't want to see publicly discarded needles.
Yeah, and then again, I just before Councilor Manich, I know has another question, but I just want to talk about that cleanup too. Because I don't think that people understand there is an actual small network of people that are doing some of that work behind the scenes today. I want to take my, want to give some recognition to the harm reduction group today that do some of this stuff informally, as well as our public health nurses do a great job. And our community safety officers will sort of take care of certain things. But again, what's been reported from where I sit, get an opportunity to sit on the plate signal, I don't hear all that. This is, we're bringing home buckets, loads of discarded needles daily. I'm not saying they're not finding one, which is too many, but I'm not, I don't hear the same, concerns that people see, so. But it is a concern.
Communities do have those concerns where there's like, there can be 20 needles at one spot.
Yeah,
By
exactly.
day.
That's what I
Yeah.
usually see.
And that segues exactly into what I was gonna say. Yes, it's 10 years ago, but the deputy chief, Jennifer Flett, and I, we went and picked needles up from the boat launch to the bridge. We picked up over 150 needles in half an hour.
Yeah.
Right, so we do have these hot spots, we do have these areas
Exactly.
that are issues. And my actual question is,
If I can
Yeah.
just comment on that before, Dr. Randy, that's exactly why we want a community response, because the second we see a hotspot, we want to mobilize and put a drop box there.
And there is-
outreach
there's one
team there
now,
to say,
yeah.
hey, folks who are using drugs along here,
Yeah.
let's talk about why you're using drugs along here,
Yeah.
what's going on? And then if you are, here's the drop box and here's,
And that
And then
Dropbox
figure out
is
how to
there now,
connect
under the grid, which is great.
Yeah.
I think that's a great location for it. However, that leads into my actual question. So you had stated that the majority of distributed needles do end up getting disposed of properly.
Mhm.
I'm not gonna dispute the fact, but what does that stat look like in terms of public consumption, not users as a whole? Because I think the public consumption, I think that number is going to reverse itself.
so, good job distinguishing the two. People who access supplies, do it in their own homes, have their way of doing it. The number one cause of publicly discarded needles is public drug use. And so that's why we want to start thinking about that housing first model. How do we get these folks indoors? Because that is where we will see the majority of that. Some of those folks will have their safe ways of disposing. They'll either take the little 10 Sharps containers, I can fit 10. And then, or they'll put it in their Pepsi can and then take it off to the primary care and dump it in there. Or they'll put it in the Pepsi can and find the closest garbage can, throw it in there. Not Pepsi can, sorry, Pepsi bottle. But that is where that will come from, Randy, is directly, or sorry, Councilor Manage. It'll come
He's
directly
fine.
from people publicly using. But and that's why we want to think about safety in general, because there's this safety, but there's publicly discarded needles, but I'm sure community members also have concerns about people being intoxicated in public, right? And so that's where, like, which one has more harms, and then how do we collectively start to deal with the public intoxication so that we can move people indoors to be intoxicated indoors where it's not a threat, or there's no safety concerns for the kid.
But is it not kind of the same thing, like if you have somebody in the back lane behind the liquor store handing free bottles or free liquor out to the youth going by? Isn't that the same thing as RHIA handing out free needles? Free pipes?
Well, one's handing out the substance itself, the other one's handing out no substances, which means people are acquiring their substances over here. But in this one, that's people handing out alcohol, but regardless of how people are getting their substance, we don't want anybody using outside, period, whether it's alcohol or anything else. We want people-
But the addictions to increase. If you have to bring your needles back, you have to do things properly and it has rules to it. There's less people likely gonna go into that direction than if you just have an open door policy and you can go get them, drop them wherever and go back and get more and drop wherever. It's no different than if you have somebody, I would say, just handing out free alcohol to whoever, you're gonna increase the addictions. You
So,
make it easier for them to live that style of life.
so that's not what the research shows, that regardless of how people acquire their substances, about 1.3 to 1.6% of the population will have substance dependence, and then up to 10 in every one of our communities, up to 10% of people who use, no matter what substance they use, will have some harms related, like problematic substance use. And then some of our communities where we have lower access and more oppressions and stuff, we'll see up to 20% of the community having problematic use. So that doesn't matter, because problematic use isn't about access to the substance. Problematic use, and this is like, now I'm delving more into harm reduction, but problematic use is dependent on adverse childhood experiences, trauma, mental health, and lack of access to address those things. That's actually how we see problematic drug use happening, because the majority of people who use any substance, including alcohol, don't have problems with it. And so then what we want to look at is why do some people have problems and some people don't, and that really has to do with mental health, adverse childhood experiences, significant traumas, that sort of thing.
Just like two less things. No, it doesn't have to. Yeah.
No, just
I'm digressing.
just out of respect for time, guys, this meeting was for 1 hour, but if everybody's okay, we can carry on for another 20 minutes or so. I don't, it's a super important topic, so I just want to respect everybody's time, so we'll try to get to the bottom of the hour and sort of be done.
Sorry, I got past, so does Carrie want to make that comment? Or who wants?
Yeah, Carrie's.
Comment on
Probably, I'll ask you.
Yes, she mentioned something of host model, housing host model on.
Yeah, I'd love to be able to comment on what a housing first program looks like.
Yeah, so maybe just come up, I know it's, this is Stephen from the,
That's the constituency.
Canadian Mental Health Association, so when it's heard, I know he's in town, he's a big executive, he works out.
I can
Or I
also
came in on a private jet, leaving at 2
quick
o'clock.
share some of the details, like we could send some links.
Yeah, no, absolutely, yeah. So just a few comments about a housing first program. I've been traveling from Dauphin to Swan River, I'm in Paw, and the work that's being done in the valley is tremendous. The need is enormous. And these conversations are essential. We want to compare apples to apples and not apples to oranges, right? So when we think of what happens in an urban area and what happens in a rural area, I can't comment on those things, but what I know is what a housing first program looks like. And in terms of success, let me just share just a few.
Stephen, just quickly though, could you just say your name?
Oh, yeah, sure, yeah. I'm sorry, yeah, Stephen Sutherland, I'm with the Canadian Mental Health Association in Winnipeg. I direct all the philanthropic activities across our province for CMHA across Manitoba. So
Okay.
looking at partnerships, looking at how do we build the team to do it, it takes a village to do this stuff. When we talk about housing first, we're really talking about something very simple. People do better when they have a place to live. In rural Manitoba, I've seen the pride of my colleagues and others who want to know their neighbors, who want to notice when someone is missing, and also when someone is struggling, sleeping in a car, couch surfing, or living outdoors, everything else becomes harder. I heard just a few days ago, a person who spent 6 months living in an abandoned car. Why? Because his house burned down in his community. And he sought help, and the only place he could find was an abandoned car. Housing first starts with a clear truth. You don't have to fix everything in your life before you deserve a home. A safe, stable place to live is not a reward, it's a foundation. I believe it's a universal human right. Without housing, it's impossible to manage health, recovery, or work. It's hard to keep appointments, hard to store medication, hard to stay safe, and hard to believe that change is possible. Housing first changes that. When people are housed, emergency calls go down, hospital visits go down, public drug use goes down, and people begin to reconnect with care, with community, and most importantly, with hope. This approach works especially well in rural communities because relationships matter here. I've seen that in the last week. Relationships fuel connection. This approach, again, works incredibly good here in rural Manitoba. When housing is paired with local supports, healthcare, mental health services, harm reduction, and community outreach, people don't just survive, they stabilize, they heal, and many move forward to flourish, to thrive. Housing first is also a smart use of public dollars. It costs far less to support someone in housing than to cycle them through emergency rooms, policing, and crisis services. I heard the costs of policing in the Paw, and it is outrageous. If we can bring those things down because of the Housing First program, I know that there would be unanimous support for that. Who wants to get that sort of invoice once a year? I don't think any community wants that. But more than that, it reflects our values. And these are the values of the people of the Paw. And
Even just got about a minute left, we need to get back to a few more questions, so.
perfect, yeah. More than that, it reflects our values and the values of the folks here today. You belong here, you're worth investing in, your life matters right now, not someday. If we want safer communities, healthy neighbors, and stronger rural Manitoba towns, housing first is not an extra. It's essential infrastructure. And we see that in Dauphin, we see that in Swan River, we see that in Thompson. When people are able to invest in housing first programs, the wraparound service that's required makes all the difference. Thank you.
Thank you.
Thank you.
Councilor Marsh.
Again, perfect segue into what I was gonna say. That is where the town of Paul fails, and I think it's throughout the province, is we don't have a wraparound service. Right? And that's why I keep referring to it as harm reduction working in a silo. They're doing their task, but there's nowhere for them to send someone. Crystal has someone that does want the help and legitimately wants to do better within that community or their home community, whatever it may be. They don't have that option. And so that's a failure. So again, segueing to what you're saying, and it's not a question, it's more of a statement because nobody here has this answer. I could probably drive through the town of Paul and identify at least probably 10 Manitoba housing units that are not available. Why is Manitoba housing such a failure on this level of this conversation to network and everybody, mental health, harm reduction, everybody working together to get them into housing? When I say you can drive the community, whether it's completely burnt out units that have been sitting for multiple years, not saying 6 months ago, we're saying for years, there's no attention to them. So what do we need to do as a community to get the government to recognize this next work needs to happen? Because obviously there's some funding to have them in the first place. So why is it not a priority if your statistics, because I'm very data driven as well. If the statistics say get them in a home and they're gonna increase by 30%, well, that's great. Find them some employment, that's gonna increase another 15%. All of a sudden, we have them well on their way. It seems like everyone's just saying, I do my thing, who cares what everyone else?
Yeah, so just to bring some context to that conversation that the council manager mentioned. So there is actually over 30 units in the community that are actually vacant. This is stuff that we put together as a council and shared with the provincial government multiple times with every department that's actually will listen to us regarding that, especially around AMM visits, especially around our communications. We also talk about, you know, that around investing in new, instead of investing in new, provide the actual budget and maintenance resources required for the local, for people to be able to increase that process. I think, and I will send a reminder to council. I believe we did ask those questions, a couple of months back or even 6 months ago with that data. But this is again, this is a great statement by Councillor Manich and something that we do all the time. You know, we do need the resources in a community. We don't need brand new shiny stuff. We need to fix the stuff that we have today in place. It's a lot more effective. You're gonna get a lot more mileage out of it and it'll be helpful. But on top of that, is the other missing things such as, you know, there's the harm reduction model that goes along. But a lot of what you were talking about is the distribution of safe supplies. But the others, resources that are required even for our friends at Oscar's Place or CMHA, is they're missing. We can't have, Councillor Commodore has mentioned, we don't have places for people to try out. We don't have access to healthcare. We don't have housing for when they come back that's supportive. You know, all those things are missing. And as a municipality, we can't do that by ourselves. I mean, we don't have the funding. We would probably not get reelected if we put $30 million into a fee and put it on everybody's municipal tax.
Yeah.
And this is where partnerships with harm reduction, CMHC, the Manitoba government, healthcare, all that sort of stuff has to come to. So we have one united voice when we're talking with this stuff. And I think this is what the frustration is of council, is we've been talking about this and talking about it for years, and we're not getting any traction. And that's the frustrating part.
Absolutely.
We have. And so, you know, our community, I think, believes that we're doing what we can as a community, but it's not, we can't do it by ourselves. We can't fix this by ourselves. There's so many things that have to come into play. And I know this council is open to partner with whoever to improve the whole situation. We want a health and safety community. You look at our community safety wellbeing plan, all the things that are talked about in there are in there. And we wanna put the investment, we've done the first part, but what else do we need to do? And if there's things that we can do to help, please let us know, because we're open. You know, we wanna do it.
And we also want Manitoba Housing to get those houses open, because that's part of like transitional housing into second stage housing into permanent housing. Like, how can we use units that are there? Like, the idea that there's people who are homeless, yet there's houses.
I mean, but I think some of it too is that I think structurally, I think this is where you, as other departments, have to ask why that's not happening.
Yes.
Because I also wanna just maybe give, maybe give a little bit of leeway to the local Manitoba Housing Group, is that they're sort of handcuffed too with the processes and procedures that are put in place, that it's not that simple to say, let's go change a window. When the contractual structure for them to secure contractors and to be able to get people qualified to work on them. So it's a little bit of a bigger beast, but we can't stop shining a light on it, and we wanna be, I drive by every day by a Manitoba Housing unit and there's 10 windows all boarded up. And then the yard's all full of garbage, so that can be a great place to live. That's what it doesn't look like it anyways.
And Council Mayor Murphy, thank you for the opportunity. I will share with you through email the successes of 444 Kennedy in Winnipeg. We have an incredible partnership with Manitoba Housing. We've been able to put 30 individuals turn the key into housing with wraparound supports, public health, psychiatry, all of the things, all housed. So all our offices for our staff are housed at 444 Kennedy, a Manitoba Housing unit. It works. It's phenomenal. I've been doing this for 25 plus years as a therapist, and I've never seen anything like it.
Mhm.
People are flourishing because they have a place to stay and they have the wraparound services. But I'll send you all the information about Fort Kennedy, because it is quite miraculous what's
Oh,
going on.
Kennedy is that it was a community driven.
Yeah,
So
absolutely.
everyone was at the table,
Yeah.
including Manitoba House.
Manitoba House,
Everyone.
Tell everybody is at the table. Made a big difference.
Thank you much for that.
I'll make my last statement. I want to support and echo exactly what Councillor Allen and Mayor Murphy said. Perception is a big driver in this community. The invention of social media can be one of the greatest things, but also one of the worst things to ever happen in our world. But if we can start with that, it's not about burying things or hiding things so the perception changes, but it's no different than when a community the size of the fall would have 3 pawn shops. Everyone says, well, there goes the community, there goes the economy. When they're seeing needles around, whether it's the truth or not, but perception is we're in bad shape.
Yeah.
So we can help by some of the different initiatives, by a different distribution manner or mechanism, a little more support with ensuring that they're not found all over. Perception will change and then conversation can go towards the things that are maybe more crucial or more beneficial to fix it rather than complaining about it. Because I really feel needles around is more of a complaint than an issue. But we understand as a council, that is the big picture.
Yeah.
The needles are just,
And that's
the
very
trigger. Needles are the trigger.
If we got rid of all the needles, there would still be an
Absolutely.
issue of safety in the community.
Yeah. Is there anybody got anything else? So again, I do appreciate, the conversation today. And as I mentioned at the start, and I mentioned quite often, is that the conversation can't stop though.
No.
We always have to continue to try to learn about this process and why we do certain things and look for opportunities to improve it. Because if there's a way of improving that perception, because one's too many, hopefully get to the point where we have zero and we're worrying about some other safety issues. But I think it's the same thing when it comes to alcohol, we're talking about needles, but alcohol, the illegal activity around people selling alcohol after hours in the parking lot, all those sort of things. Same thing as throwing garbage out on the streets, it's no different, we talk about why we do that, but we deal with a bunch of things that are behaviors that we all should not happy about, and we need to continue to work on them, so. Thank you so much for attending today. I will mark you in the calendar for meeting again. I know, you're gonna hang around. I know, we've got maybe a couple people that would like to sort of just ask some questions after the official meeting. So with that, everybody's good. Did I get a motion to adjourn? Good, Council. Okay, so thank you, everybody, and we'll hope to see you again sometime. Just there's still.